My understanding is it's really most appropriate for patients who have type 1 diabetes. But what are tell me if I'm wrong there, or what your general thoughts are from that dietitian perspective about carb counting for patients.
Well, hey there, it's Liz Rohr from Real World NP, and you are watching the Real World NP YouTube channel. We make weekly episodes to help save you time, frustration, and help you take the best care of your patients. This week's episode is an interview with Meghan Kavanaugh. We've had her on the channel before. She is a nurse practitioner in diabetes care as a specialist. However, before she became a nurse practitioner, she was a registered dietitian nutritionist, RDN. And so in this interview, we're focusing on the diabetes nutrition counseling that comes along with the diagnosis of diabetes and the care of the patients who have diabetes in our primary care practices. I really, really loved this interview because I got to see behind the scenes of what it's really like when we send patients for nutrition support. And also, we talked about the ways that we can and cannot support patients in primary care as nurse practitioners, right? There's no replacement for a nutritionist. However, there are some things that we can do, either keep doing what we're doing or improve. But it was such a beautiful interview and an eye-opening interview for even myself coming in from this perspective of holistic care. It was really, really special. So if you are taking care of patients in primary care with diabetes and you're trying to approach dietary counseling, this episode is just going to be the best. So without further ado, here's my interview with Meghan Kavanaugh.
Awesome. Thank you so much for being here with us again.
Yes,
So can you introduce yourself to anybody who hasn't heard from you before?
Yeah, sure. So I'm Meghan Kavanaugh. I live in North Louisiana. I'm a family nurse practitioner, but I'm also a registered dietitian. So I started my career as an RD and then eventually decided to go back to nursing school and then NP school. So I currently practice as a nurse practitioner, but I maintain all my credentials for RD.
That's awesome. That's awesome. Yeah. So we did an interview, you and I did an interview for the channel before, for the channel as a podcast on YouTube. And we really focused on the diabetes care, most common questions from a nurse practitioner perspective. And so even though you're not practicing as an RDN, RD right now, I'd love to kind of talk about, with so much experience that you have and so much passion that you have, like, I think the context of the conversation, like you and I kind of just touched on before we started recording, was that so many people, some people have a resource with a nutritionist in their clinics. Some people have nothing, and they don't even have somebody to refer to. And so a lot, like what we're going on are the questions from the Real World NP community, and a lot of people are asking questions like, "Oh my gosh, what do I do for patients who have diabetes and who need support on the nutrition side?" Because it's a really holistic approach to diabetes. It's not just about medications, right? So thank you so much for joining us for this. So I think a place to start would be like, what, in your experience as a nutritionist, and you can obviously like add in your thoughts now being a nurse practitioner, like where do you start with somebody who has a new diagnosis? So for example, if I have somebody with a new diagnosis of diabetes and I refer them to your office and you're working as a dietitian, where do you even start with a person in that situation?
That is a great question because it
It's a
also
big
has
question, big answer.
the big question, because probably one of the biggest questions the patient has is, what am I supposed to eat? What can I eat? What can I eat? That's like one of the number one things that's asked, whether it be provider in or RD or whatever. And the answer is like, you can eat a lot. You can eat all kinds of things. And the where it's kind of hard to think of it now, as an RD, because typically when you refer out, one of the things, you have like a lot more time. Okay. So if you have, as an NP, you're in clinic and you have somebody that's newly diagnosed and you are trying to start medications, start some initial education, and then of course nutrition is like on the focal point for a lot of people's brains. In what time of a time slot? What, like 10, 15, 20 minutes? Like, so there's not a lot of time. So encouraging, of course, to refer out. When people especially say, well, what can I eat? I like to say, what do you like to eat? Like start giving some ideas there. And one of, also from like the get-go, is just always reiterating that you're not going to learn everything all at one time. There's a lot that's going on with a new diagnosis with diabetes. There's a lot that goes on with nutrition along with it. And it's a huge learning curve. I mean, you might have somebody that's 60 years old and they've had 60-year-old habits, and now that we're going to have to like transition. So it's a lot of motivational interviewing, a lot of feedback, not just talking at the person, but getting their feedback and building on that. And then knowing, hopefully, if the resources there, that they have multiple visits to build on things and not having to change everything all at one time. So that's a broad question without
No,
a very focused
totally.
answer.
I think
But
that's a great place to start. And I think it's so important to reiterate, especially for whether people are experienced clinicians, providers, listening, or if they're students or going into practice. Like, I don't know, that's my philosophy of practice too. Like you and I share that of like, we just meet the patient where they're at. And honestly, I feel like research supports that too, especially when it comes to motivational interviewing. Even if you don't feel super confident with that skill set, like if you starting with where the patient is and doing an assessment first, I think applies to not only nutrition, but also just like our approach as nurse practitioners in general, right? Where it's like, okay, well, where are we starting off from, right? So that's really cool. So I guess speaking from experience as a nurse practitioner working in a clinic, having worked in clinics where there's no resource in-house and we have to refer out, and some people have access and some people don't. I think I can kind of sum up with the understanding that I have of the gist of what people do when they're in that situation. So I think that there's a couple of things that people do. And one is kind of like, okay, and we also heard this from the questions from the community. It's like, okay, so where do we go? So if we've done an assessment with somebody, do we go straight to a recommendation? Because like clearly you have a very sophisticated, nuanced level of knowledge, right? And so if we're talking about like starter place one, is like, a lot of people want to do like, okay, do I do the plate method? Do I do the Mediterranean diet? A lot of people wrote in and say, I'm tired of saying just eat less carbohydrates.
oh yeah, I love that part. Yeah. Yeah.
And so it's like, so where would you go in terms of like a first step, thinking about those potential three options of like, do you use the My Plate method? Do you talk about carb counting? Do you talk about less carbohydrates, quote unquote, whatever that means? Like what's like a first place to start potentially for like a beginner 101?
And a beginner 101 might start with, does the patient even know what a carbohydrate is? So they might not realize that fruit can raise blood sugar, certain vegetables can raise blood sugars. We don't want to go in any situation just like with that assumption that somebody has the baseline knowledge, so it's like, tell me about foods that you like, your habits. Are you a snacker? Do you work night shift and you snack throughout the night to kind of stay awake? Do you have any different religious beliefs, cultural beliefs, just things like that? Because everything that you read about nutrition is right, that it's not one size fits all. So if you do say, okay, let's start with the plate method, well, that's a good starter. It's a good visual for a lot of people. It's very easy and it's adaptable for like a lot of different situations and meals. But like Mediterranean diet, it's very, very healthy. That might work for some people versus just explaining what carbohydrates are and like the focus at the beginning of like reduction in carbohydrates. So you do have to get a little bit more of a history at first to kind of figure out where they're at, because if they're newly diagnosed, like for instance, for me, like if they see primary care, they're newly diagnosed and then they see us soon after that, well, they've already probably been on Google and like looking at things, and they might have a family member that is teaching them some things. So by the time they've seen us, sometimes really good changes have already been made. They've started a walking regimen. Maybe they were drinking a lot of sodas and sweet tea and juices, and they cut that out and they've had a significant improvement already. So again, it's just like meeting them where they're at. But it is, when you're limited in that time, it is very like, okay, I'm just going to do the plate method and just start with some education there. But it might need to start with, okay, let's just focus at first. Are you drinking any sugary drinks? Okay, that's I say easy. It's difficult for people to do, but
It is.
Right out of the gate, it's like, hey, look, even if you are still having some higher carb meals, but if you're having sodas with it or drinking tons of juice or even large quantities of milk, let's work on reducing that, because you're going to see an improvement pretty quickly. So that's a good starting point for a lot of people. And even if you have the ability to have a regular follow-up with somebody, they can keep track with like even little food logs or use something on their phone, their notes app or an app where they can log some things so you can look at it. But again, that's where ideally you would have a registered dietitian doing that. But of course, not everybody has that resource. So
Yeah.
it really just, I hate to say it depends, but it really just kind of depends on
No, it's
where that
true.
person is.
It's true.
And then a lot of, there's good resources online, like good starting places where it's like, even if you say, okay, I'm going to get you in with an RD, but here's a good resource that can be printed off from, American Diabetes Association, AADE has good ones, Diatribe, which I can give you the links for those. And of course, like the My Plate, but something that's a good visual, that's
Yeah.
basic, just to start getting some education for that patient.
Totally. Oh, I love that. Do you feel like, is this, my intuition is that it's also a patient dependent thing, but do you feel like, are there any sort of like standards that you follow as a dietitian, or the dietitians follow, where it's kind of like, here's the ideal amount of protein, ideal amount of carbs, ideal amount of, like, does it ever break down like that? Or when you come and you do a follow-up with a patient and you've started at that place with them, when you do their follow-up and their blood sugar maybe has improved, but it's not like at goal yet, like, where are your places to go for that? Like, what is leading your thought process there? Are you looking, like, it sounds like you're probably going to assess what their meals are, but are you simply targeting carbohydrates at that point? Or tell me a little bit about that when it comes to if you've started. So for example, if in the primary care clinic, you start with reducing milk, which actually has a lot more sugar than I think a lot of people realize,
Yeah.
and juice and sweet tea and stuff like that, and sodas. So say they've made that change and they're not at goal, where's that next place that you're kind of going with that person? Is there an ideal, or is it really targeted based on that person and their specific A1C, for example?
There are different targets, and it depends on the guidelines that you read for different percentages of calories that come from the different macronutrients, fat, protein, and carbohydrates. I mean, like, even when I was finishing RD school, like, the amount of carbohydrates that were recommended were just like, wow. I mean,
Like a
like,
lot?
wow. Yes, it was a
Yeah.
lot. And so finally, it was like, I don't know, might be a year or two ago, they finally said, hey, a very low carbohydrate diet can be appropriate for certain patients and populations. And with your question about, okay, certain percentages, for there, I also just assess with the patient how detailed they want to be. Because when you start getting into like macro counting, and if you're wanting them to count every gram of everything, that's a it's a big job, and not everybody wants that amount of data.
Yeah.
And it's also very, very time consuming to teach.
Yeah.
So but yeah, there are, depends on the patient, their goals, if they need weight reduction as well, and percentages of each macronutrient, then kind of going from there, and you can convert it into the number of recommended carbohydrates, like per meal, so that's kind of a good starting point, especially when you're getting into carbohydrate counting.
And carbohydrate counting, my understanding is it's really most appropriate for patients who have type 1 diabetes. But what are tell me if I'm wrong there, or what your general thoughts are from that dietitian perspective about carb counting for patients.
Yes, for type 1, for sure, because ideally with the carbohydrate counting, knowing how many grams are consumed at the meal, whether it be 12, 26, or 64, it's converted ideally with the math for an insulin to carbohydrate ratio, so that patient is dosing their insulin based off the carbohydrates that are consumed. But we also do like carbohydrate counting for people who have pre-diabetes, type 2 diabetes, because it's not even to be like so precise for that insulin dosing part of it, but also to be cognizant of foods that can potentially raise the blood sugar and then the amounts consumed at that time. So we do, with that, we'll teach that, but maybe not as to like a precise amount, where if you have somebody that has type 1 or type 2 that doses for an insulin to carbohydrate ratio, and let's say they're very insulin resistant and they need 1 unit, for example, for every 4 grams of carbohydrates, which is pretty strong. That's 2 saltine crackers. So you say, okay, well, if you eat 2 saltine crackers, that's 1 unit of insulin. So to that precision, the carbohydrate counting is very, very important, and ideally done in the most accurate way possible for correct insulin dosing.
Yeah. So that's pretty involved for most patients, though. So I saw a number of questions, and I've heard a number of questions, just like in among mentees and in regular life and stuff about what, different kinds of diets. So I think that there's different levels of health literacy depending on the patient. And some patients might come in and have done all this research, and they might come in being like, I'm going to do like a ketogenic diet, or I'm going to do a paleo diet, or I'm going to do a plant-based diet. Do you have any thoughts about that, when patients come in with that, with those kind of approaches to their diabetes? Or what kind of conversations
Yeah,
do you have with them when they bring that up with you?
right. And it's more, I think of it like more of an eating style,
Mhm.
maybe instead of like diet, like kind of the labels on things, or somebody saying like, plant-based diet, but I'm going to be vegan. But every now and then I do want to have a little bit of animal-based proteins. Like, let's just not
Mhm.
call it vegan, if it's
Yeah.
not more of
Yeah.
a like an ethical type thing, and you're just wanting to do more plant-based, you
Mhm.
don't have
Mhm.
to call yourself vegan, right? Or because I like the term like the flexitarian, like just
Yeah,
kind of
totally.
different options. But especially when you start getting into keto and somebody says, well, I want to go keto. And I'm thinking, okay, do you mean low carb, or do you mean like true ketosis where, it's a very, very high fat, very, very low carbohydrate diet? So sometimes people say, I want to do keto. They just really kind of mean, I want to reduce my carbohydrates. Like I know I can, lose weight doing that.
Yeah. Yeah.
So, and then I will also put back what their typical eating behaviors are. And it's like, do you feel like this is something that you can do long term? And we
Mhm.
have, of course, there's people out there that are highly motivated that can stick with like a style of eating long term. But I
100%.
also want to reiterate to them that they're not failing if they don't eat that style 7 days a week, every week of the year.
Yeah.
So with things like keto or low carbohydrate, I mean, generally, especially if somebody is checking their blood sugars, and because we want to minimize hypoglycemia always, but if they have a continuous glucose monitor and they're able to see the effect of carbohydrates, even low, moderate, high on
Mhm.
that CGM, a lot
Mhm.
of them kind of naturally shift to like,
Mhm.
wow, I had no idea that milk did that to me, or
Yeah.
kind of the obvious stuff like cereals, like something that's high
Yeah.
processed carb, and you're like, oh, please throw it away, just get it out of the house. But so they can look at that data and get more of like an instant feedback,
Mhm.
whether it be through finger sticks or through a CGM, and it kind of you add some self
Mhm.
motivation that way too.
Oh, I love that. I love that. I almost wonder if you want to like do a pretend patient. Like if I was your pretend patient. But I'm like, I don't
Like
know
an
if I feel
interview.
comfortable sharing my dietary habit.
Like if I was going to be your dietitian.
Yeah, just like as an
Is that what you?
example, like how it would go. To
Oh
just, I guess, because
wow.
like I think part of it is also illustrating how complicated it is, right? Because
Hmm.
this came up with a physical therapist too, where it was like when I did the physical therapy interview, I think everyone's inclination, and I don't know if you feel this way too, is like, what exercise sheet can I give them to fix this problem? And they're
Yes,
like, holy
yes,
shit, this is
yes.
it's way more complicated.
Oh, I know. I mean, just like that question about the my plate versus, and it depends. I just feel like I'm saying it depends for everything,
Mm-hmm.
but it does. I mean, it does. Like that's an honest.
Yeah.
But people
I
want to
want
be like, here's a sheet for this, here's a sheet for this, here's a sheet for this. Yeah.
exactly.
When I worked outpatient education, and if it was somebody that came in just for weight management or type 2 diabetes management, I didn't have many patients at that time with type 1 diabetes. Um, they probably, it was referral only. Okay. So when they came in, they've already seen their primary care. We were education only, no management. And they would see the registered nurse either that visit, or like on the same day, or they would come back another day with some food logs and everything. If somebody
Mm.
just like came in and they did not have any food logs, I started with, give me a history. Okay. What do you typically like? And I had these sheets, and I said, okay, what do you typically like for breakfast? Give me some ideas. Do you eat breakfast? Jot it down.
Mm.
Okay. What do
Mm.
you eat for lunch? What's your work schedule like? Tell me
Mm.
about that. Do you snack? What do you
Mm.
snack on? What do
Mhm.
you have supper? Do you skip meals? Do you feel low in between meals? Are you a stress eater, emotional eater? Are you a stress non-eater?
Oh, I love
And do you
that.
snack at night? Okay. Do you work nights? What do you do? How do you stay awake? What do you drink? How much? How much water? Like you get this huge history. So I would have, because I'm
Mhm.
a pen and paper person. Okay. So
Mhm.
even with all this technology, I'm like, just writing all these things down. So then I say, okay, look, this is your normal routine. Let's make improvements on this. Okay. So you drive a truck, you drive cross country, and you have fast food and restaurants. What are your favorite fast food places? What do you like to get from there? Okay, you're not going to pack anything, and then we need to do fast food. Here's what to get. I mean, so it was like examples based off of their history, like at that time. So they came out holding something. It says, oh, when I go get pizza, this is what I need to look out for. When I go I'm working nights, these are some ideas of things that I can pack based off of the foods that I like. I mean, so it's like very history based and then improvement based off of their current routines. You see what I'm saying? So that's why it's hard to say, hey, like my plate is great. It's a good
Yeah.
visual, but
Yeah.
still, if you have somebody, okay, we do half plate vegetables, but the person's over here like, I don't like any vegetables. What am I supposed to do? I'm not going to eat a single vegetable. I'm like, what vegetables do you like? Well, I like green beans. Okay, let's put some green beans on that plate and let's build from there. So you can be talking at that patient or like recommending Mediterranean diet and they can be allergic to fish. So it's like,
Yeah.
it's just it's more like history. That's why like I don't even generally recommend saying like I don't say, hey, let's do the Mediterranean plan. It's like, no, let's try to get good, healthy, fatty fish and let's get, foods that reduce inflammation instead of like calling it something. And that's why it's so hard because like again, we want to hand somebody something that's just, hey, eat this, this, and this, which
Yeah.
we have the same handouts, but we've come up with them. Like these are the foods that will raise your blood sugars. These will help keep it steady. And that's still a good point, but it's like the application to real life. You see what I'm saying? Like that's where
Totally. I think that, yeah, I mean, I think that's the thing, like, with that physical therapy interview, everyone wants to give that handout, do this exercise when you have back pain. And it's like the hardest part of like, I think and I'd love to hear your perspective on this as both an RD and as a nurse practitioner. But for us, I feel like the main challenge sometimes is the diagnosis for some conditions. And then once you get there, the managements are pretty clear, right? There's nuances and there's choices, especially when it comes to diabetes, right? Like you have to be a little bit more sophisticated nuance there. But for the most part, like I think that the main challenge, at least newer grads and newer grad nurse practitioners have is like getting to the diagnosis. And it's like, okay, what's the algorithm of management, right? And I think that with physical therapy specifically, like I know for a fact from like doing all of that stuff and then doing that interview, right, is like, oh, that's the easy part. Right? Is it an orthopedic problem or is it not? And if it's an orthopedic problem, here's all of the sophisticated management. So yeah, it really sounds like with RD, like that's the same thing. But I love those history questions. Like I really love how much that illustrates why it is so sophisticated. And I think it's really hard. And I think I really appreciate you coming on and talking about this because this is the huge challenge. And I think it's like at least I know I feel this way and I feel this from other people is like this responsibility to like take really good care of our patients in a system that is not set up to support patients' optimal wellness. And so it's like, okay, how can I be an RD? How can I be a physical therapist? How can I be the specialist? Right. And the reality is we have to draw the line somewhere. And it really sounds like with RD and dietary education, like there are places we can go and I think we can get better at of like what history questions to take, right? Because like I'm not asking things like, are you an emotional eater? Right? Because I'm not really like prepared, excuse me, to have that conversation of like, where do I go from there? They answer yes. I'm like, okay, what do I do next? Where do we go from there? Right. And so it's like, so yeah, so I really appreciate that. It sounds like some places to go though, with the knowledge base that we have as nurse practitioners is perhaps getting really comfortable. What are the blood sugar raising foods versus blood sugar lowering foods? And then like, how can we get better at the history and how can we develop our knowledge to be more sophisticated such that we can take the fast, like that's a beautiful, beautiful example because that's real life, right? Of patients who they're a truck driver across the country and they only get fast food. Like what other options are there when you're out like driving? Like, I don't know. I mean, I've been on really long trips where there's a lot of truckers and it's like, okay, well, here's one option in the next 45 miles. So, so that's really cool. That's really, really helpful.
And that is, I mean, you talk about like getting to the diagnosis and like, where's the algorithm? I mean, if you and I compared like schedules, routines, food likes, dislikes, you're going to get two completely different people on paper, right? So, right now my husband's traveling for work and I'm just making like an egg sandwich at night for supper because I'm not going to cook a big meal. And right now, just like in the season of life, yes, I know vegetables are very, very healthy, but they're also expensive and they go bad. And, so right now I'm focusing on steam bag vegetables that cost $1 and I throw them in the microwave. They're done in 4 minutes, a little bit of salt and pepper,
Right here, same
it's
person.
fiber, it's fiber. So where you look
Totally.
at like even like social media and like these beautiful, like great meals, the always like telling that patient it doesn't have to be that complicated. It doesn't have to be that expensive. Food, I mean, costs of everything obviously are crazy, but it can be, make it like as simple as you want while as nutritious as you can and doing the best you can in the season of life right now. I mean, it's like that's the takeaway. So we know every year holiday season people are going to indulge and have this, like, okay, if you have your grandma's favorite, or the grandma makes your favorite chocolate pie, okay, but you don't really care about pumpkin, don't eat the pumpkin pie, eat the one that you like, maybe cut your carbs back a little bit, kind of acknowledge it, but make a holiday, not a holiday month, just celebrate the day, but don't make it go to a whole month. And you can still see improvement. So even a lot of these patients are coming in after the holidays and still have a lot of people that are having really good, consistent weight loss. They still have decent blood sugar control. There's some periods of time that get a little wonky, but it's like learning those little mechanisms of what do I do in the situation? What's the best decision I can make right now in the situation, the social environment that I'm in right now? And it might be a reduction in portions. Like if you can't control the quality of the food, control the quantity of the food, like just reduce it a little bit, drink water, try not to overindulge in alcohol, limit it to maybe one sweet instead of three, like little things like that, just over and over. Perfection, not perfection, but just improvement. You just want improvement, and then where they can see some success and kind of build on that. And those are the ones that can really long term have success because they're realizing that I don't have to do exact macro counting to get everything right with the meds that I'm on and my routines and other things that we're dealing with. So
I love
that's
that.
why, yeah.
No, I love
Nutrition
that.
is complicated. And I think this is why, when I went back to nursing school and some friends said, oh my gosh, our nutrition class is that I hate nutrition. I hate nutrition. It's really, it's hard. And it's a lot of hand holding and, food is very emotional. It's very,
is.
I mean, there's more, you say, you don't ask the question of like, are you an emotional eater? Because what do you do with the answer?
Yeah, well, it's just like it's like that whole like depression screening thing is like it's not
Uh-huh.
recommended to do a depression screening unless you have the resources, right? And so unless I'm like I can think through that and think about how I respond to it, but just like hearing you say that in the moment, I'm like, oh gosh, like I don't even know. I don't think I've asked that of somebody before. And like because I think like especially like that's I don't know if this is your experience, but my experience of becoming a nurse practitioner, like when I was brand new, I was really focused on like, what is the safest thing that I can do so I don't miss anything. And then as I develop in my practice, I get into those deeper levels of sophistication where one of the things I was going to say in terms of like, part of it, like, I think hopefully this is awareness raising in that like one individual person, me, myself as a nurse practitioner cannot fix a system that is not supporting the anti-wellness of our patients, basically, right? And so, but like, what are the things that I can do in my scope and how can I raise this as an issue and talk about it with other people? Like we need RDs, we need physical therapists, we need interdisciplinary collaboration for a reason, right? But like, that's one of the things I was thinking about is like, how can we, like one of the ways potentially we can do it in primary care, like it's not against the rules to have somebody follow up in a week, well, probably not a week, depending on how much space you have in your schedule, but like in 3 months, if you how often do you follow up with people in nutrition? Like every month or every
It
2
depends
months?
on their insurance because, with Medicare guidelines, Medicare will cover reimbursement for registered dietitian for nutrition or it's MNT, medical nutrition therapy for diabetes and then for renal. So for your patients who go to dialysis, there's RD on staff and then they get nutrition counseling, while at dialysis. So there's a certain amount, you get a certain amount of hours, and I should have looked this up because I don't think it's changed, but certain amount of hours of like initial MNT, like so the first time that they meet with a registered dietitian, and then a certain amount of follow-up There's also each year they're allowed to get kind of like refreshers. So it does kind of depend. Like, so Medicare, keep that in mind. There are also a decent amount of private insurance company like Blue Cross that will allow like a certain amount of MNT time, of course, subject to like deductible and copay and everything. So it just kind of depends on how much support is needed. And when especially at first, when somebody's newly diagnosed and you're trying to teach these things, from a RD perspective, if you have the capability to have a pretty close follow-up, even 3-4 weeks, a month, 6 weeks, something like that, where they
Totally.
keep, I like food logs. Like I think that's very helpful. It's not only for like, from my perspective of like some cause and effect, especially when I look at like some more detailed insulin management, but also when the patient is thinking through, I'm going to have to write that down. Like I have to write
Yeah.
down that I had, some Oreos for a snack,
Yeah.
and you present this if you decide to do this with your patient, because the data is not just great for you, but it's a really great eye opener for that person, especially when you catch them when they're motivated. Like, not, I don't use like fear as a scare tactic, but
Yeah.
a new diagnosis, like I'm going to change all the things. And
Yeah.
so they're motivated and they want some feedback. And, as humans, we like positive feedback, but telling that person, this is not to grade you, this is not to judge you, this is not
Yes.
to like grade your papers. I just kind of need to see what's normal for you. Like, hey, you know what, if you go fast food 7 days a week, we're going to work on that, we're going to cut it back some, and
Yeah.
that's going to save you money too. Like, you'll see a higher account balance at the bank because you're not spending $10 every time. So finding
Totally.
that of, it's not something to use against them, because again, food being emotional,
Yeah, you're so right. Yeah.
yeah, it can be kind of an embarrassing thing. Like, oh
Yeah.
wow, I really drink like 4 sodas a day. Like, this is bad. Like, they're gonna fuss at me. It's like, no, just to help. Let me help you.
Oh my God,
Let's
I
make
love
small
that.
changes.
I
Yeah.
love that you brought that up, because in a part that we're not going to include, I was potentially offering to be your example patient. And even I, as a nurse practitioner, trying my very best to be healthy, I'm like, oh, I don't know if I want the whole world knowing what my dietary is, right? And like that,
Oh
it,
yeah.
it feels that same magnitude for a patient in a clinic, especially if they write it down, especially when they have to give it back, especially if you have that emotional eating components, right? Of like, there's a lot of feels in there. So I love
A
that. I
lot of feels.
appreciate
Oh
that.
yeah. I'm at this desk right now, and it's like, I wonder how many people would be like, oh my goodness, she's drinking Diet Coke that has so many chemicals. But it gives me caffeine and I enjoy it. And I drink a lot of water. Like, there's worse things. Because
Totally.
I talk to my patients about that, because they'll say, well, I would rather have regular sodas because at least I'm getting like real sugar and then not having like the aspartame or, whatever other artificial sweetener. It's like, yeah, but if we look at like the hierarchy of like what's healthy, what's not, it's
Yeah.
health promoting
Yeah.
versus like health neutral versus health harming. Like,
Mm,
yes, I usually have a Diet Coke on my desk, but I'm also flushing it with a lot of
mm,
water. So I can't say don't drink
mm,
them if I'm doing it. And
mm.
so, just things of just letting them kind of realize that you're a person too. And,
Yeah,
your real world too.
absolutely.
Yeah.
Absolutely. And I really like,
Yeah.
I think especially for newer grads, I remember feeling this way myself of like, I felt like such an imposter. And I was like, I just like, I need to prove myself even to the patients where they're like going to think I'm an idiot all the time. Like, if you're feeling like that, that's super normal. And also, the more experience that I have, the more comfortable I am with saying things like, I don't know, the more comfortable I am with sharing my own humanity, because like, it's coming from a place of I'm just sharing. It's not like you need to like, I'm not like putting it on my patient, but at the same time, like when you share that you're a human too, like people are going to feel more comfortable.
Oh yeah.
I want to go back to what you said. I guess like a couple of what I'm trying to tease out is like, it sounds like, we need to do like one opportunity is that we could do more assessment questions and asking and really getting a sense in a deeper way of how people are actually eating on a regular basis, not having any judgment about it. We can do our own follow-up visits as primary care, as a health dietary counseling visit, right? It could be a diabetes related follow-up, for example, and we can have these conversations. I don't have the skill that you do as a registered, dietitian, but at the same time, I can do my best. And then, just another recap, thinking about high glycemic foods and lower glycemic foods, and potentially considering substitutions as like one, like quote unquote hack. It's not really a hack, but like what is one like small change? And what are some of the other, like when you said making the best choices in the moment, like what are some examples, or if you can recap what you shared about the best choices in the moment, like what are some of the other examples that you give for patients of like how to make their best choices, whether it's like a fast food, like here are the healthiest options at this fast food place versus is it a smaller portion size? Do you know what I mean? Like what are some, can you think of any other examples of patients where what is their guidance of making the best choice in the moment?
So if it's more of a situation that's let's say social, like family gathering, and potluck style, something where there's going to be quite a few dishes, I'll encourage, hey, you be in charge of something that's healthy, that that you enjoy, that you get joy from, that is going to promote some wellness and not just shoot your sugar. So if you know that, hey, this salad that I make with this salad dressing that I enjoy, I like the way it tastes, I enjoy it, other people would benefit from it too. So you kind of have a food going into it that's kind of safe for you and not so much like a become like trigger food. So if there's like tons of different types of starches, which a lot of times in those social situations there are, okay, like you're gonna have some, but what are your favorites? Okay, so let's think about Thanksgiving. We just had Thanksgiving a couple months ago, and I love asking the patients, this like coming back, how's the holidays? Like, what's going on? Like, what was the best thing you ate? Tell me the best thing you ate. And I do this right now, so not as an RD, and like I'm in Louisiana.
I love
Okay,
that.
so we have
Bringing some positivity around food instead of just like, oh my gosh,
like,
I did a bad job over the holidays.
yeah, like how much pumpkin pie did you have? No, it's
Yeah.
not non-judgmental at all. And then you get that comfort level like that from them, because it's hard to talk about food, and again, it can be embarrassing for some people. But so because if they don't want to say, oh, I don't know, I cheated, I was bad. And I don't like when people say they cheat and they're bad. Like, no, you're human. You are human. So I'm like, dressing, that's my thing. Dressing, like I don't care about
stuffing for the
anything else.
Northerners is
Yeah,
dressing.
yeah. My mom's dressing or my mother-in-law's dressing. Like, give me a pile of that and some turkey, and like I'm good. So then
Best.
they'll say, oh yeah, that was my favorite too, and I'll say, because I don't really like. This is me, talking about. I'm using myself as a patient. How about that, Liz? Instead of using you as a patient, like I don't really care for like seasonal desserts like pecan pie and pumpkin pie and stuff. So I'll tell the patient, like, yeah, I don't like that stuff, but I'm gonna eat some dressing and I'm gonna enjoy it because I can only get it this time of the year. What did you like? And they'll a lot of times like, oh yeah, it's my aunt's sweet potato casserole and I had that, but I did good because I ate some extra turkey and I didn't have that. It's an accomplishment. So
Yeah,
those types of
absolutely.
things and environments, because we are going to have holidays, we're going to have birthdays, we're going to have events at schools, and there's going to be things. So is when we're talking about like how difficult it is to say everybody gets the plate method, or everybody we're going to hand out Mediterranean, hand out keto or whatever. That's not real world a lot of times. So it might be having, okay, I really want to enjoy this piece of birthday cake, but I'm not going to have ice cream on top of it. But that doesn't mean eat double the cake either, like negate that. But when it comes to, that's a long answer for your short question.
No, it's
but
great.
it's like these little tangible things, and they remember that. They will remember like, oh, I went and saw Megan and she was just saying, like, if you don't like something or you can get it any other time of the year, why kind of like waste something on that, meaning like a special food.
Yeah.
So when it comes to restaurants and fast foods places, now most chains have their information online. Okay. And I used, it's easy, kind of the easy thing to think about is like, okay, if you go and you sit down somewhere, think of it as the plate method. And for people who aren't as familiar, half plate vegetable, quarter plate protein, quarter plate starch. Okay, so quarter plate of something that could possibly raise blood sugar. Most places that you sit down at have a lean-ish protein option, a starch, and then a non-starchy vegetable or salad. So it's like, if you think of that plate as the platter that they're going to give you in this huge portion, that's a win. Just, if you usually get a giant plate of pasta, but the healthier option is to get a protein, vegetable, and a small amount of a carbohydrate, that's a win. You know, that's a great improvement with at the same restaurant somewhere you enjoy, if it's date night or whatever. And
Mm-hmm.
then kind of the same thing with fast food restaurants. If it's
Mm.
somebody that's traveling and um, you know, they just didn't pack something, or because that would be, you know, this ideal world that we say, but people
Mhm.
would pack all their stuff, but that doesn't happen.
Mhm.
And so, okay, if you run through McDonald's, look at the menu, kind of look at the carbohydrates, look at the
Mhm.
different amount of carbohydrates in a small cheeseburger versus a quarter
Mhm.
pounder with cheese. You know, there's a difference there.
Mhm.
They
Mhm.
have, most places now have little side salads, or they have, you know, apple slices or something. But I always tell them, no matter what, no sugary drinks. Just don't get us like just reduce it. Like a Diet Coke does not cancel out or a Coke, you know. So it's just it reduction in portion sizes to kids meals. You know,
Mhm.
that's another good option where
Yeah.
it's just
Mhm.
automatically tailored down, and most of the times it's satisfying enough. We're kind of taught over time to not really think about satiety and eat past the point of fullness, and or don't waste things that are on your plate, because
Mhm.
you know,
Mhm.
you're just kind of pushed if you were kind of that generation. So people don't even really
Mhm.
recognize when they're
Mhm.
actually
Mhm.
satisfied versus like stuffed to the brim and then feeling sick. So you know,
Totally.
just then you start getting into more intuitive eating too, which
Mhm.
like everything else takes a lot of time. So
Yeah,
yeah.
absolutely. Absolutely. It kind of reminds me of like when I talk with parents, do you see kids? I can't remember. Do you see are you family?
Yeah,
Your
we do
family.
see
Yeah, yeah.
mhm.
But like with kids, like when I talk with parents about or the caregivers of young children, like about picky eating, and it's kind of like, and obviously I would love your take on this too, but
Yeah.
with the way I talk about it with them is kind of like um there's a lot of drama that gets created between, there's a power dynamic and kids can only control certain things. And that's one of the things is like what comes in and what goes out of their body, basically.
Mhm.
And so it's like if you can remove, like try your best as the grown up to like put your patience, like work on the patience of like letting all the drama be out of it, letting all the feelings be out of it. And also trusting your child to know their like it can be a process and every kid is a little bit different, but
Mhm.
it's like the main goal that I talk about with parents is like how to encourage your child to be aware of when they're hungry and when they're full and like allowing themselves to be done because
Mhm.
and obviously you have some behavioral stuff in there where somebody will eat like a bite of something and then like before bedtime they're like I need to eat this whole thing, right? But it's like even with adults, like I know that it's easier when kids like that they start off with that, but like even as adults, like we can have conversations about that of like thinking through those pieces too of like, like do you know when you're full, do you know when you're hungry, like what are some
Mhm.
things to practice around there too? So
Yeah. And what does that feel like? Are you like, how quickly are you eating? Like, are you a nurse at the hospital and you have to eat in just a couple minutes just for
mhm,
literally to get calories in your body
mhm,
to and get some
mhm,
sort of nutrition? So
mhm,
and yeah, I mean that's, I would say that's very challenging to teach,
yeah,
like knowing like hunger cues. And
yeah,
then, you know, since we're talking about diabetes and with like weight management, you
yeah,
know,
yeah,
the GLP-1s,
yeah, yeah, yeah.
that's one of the things that's so helpful. I mean, when these patients come back, and I told you before, like we started, I was like, I really don't want to get into like weight loss,
Yeah, yeah,
but
yeah,
I'm going to kind of
totally.
dip into it a little bit, like from the diabetes perspective. When
Mm-mm.
you've had somebody that has struggled with weight management, and you know, because obesity is not being treated with it, it's just it's that's kind of a problem in and of itself, with kind of limitations on medications and insurance coverage and everything without diabetes. But we know that it can help prevent diabetes.
Yeah,
And
yeah.
so if you have somebody that's been told their whole life, you know, that like your BMI is too high and you're overweight, and you know all
Mm-hmm.
this, and there's such a this negative connotation with food, and then you
Mm-hmm.
have one of these medications that all of a sudden, when patients come, like, I'm not obsessed about food, you know, like it's great, like I can get halfway through my meal and I'm like, I'm good, like I've never had that ability
Mm-hmm.
to be able to
Yeah.
stop, or to realize that, wow, I
Mm-hmm.
really am not that hungry and I don't need to snack four or
Yeah.
five times a day. And in that regard, kind of have that, because the medication makes you full,
Mm-hmm.
or, you know, it makes you full fuller longer,
Yeah. Yeah.
amongst other ways of just how it kind of shifts the brain and creates a lot of like positivity emotionally too, because there's
Mm-hmm.
not as much of a obsession with like snacking and binging and things like
Mm-hmm.
that. But that goes
Totally.
down another rabbit hole.
Totally. Oh my goodness.
Yeah.
Oh my goodness. You're so right. One of the questions I really loved that was submitted was, what have you counseled patients on that they seem most surprised to hear? Is anything
Oh,
come to mind
wow.
with that?
In regards to foods in
Like,
general,
yeah,
or?
just like, I guess like when you were working as an RD and you had a patient come to you and you started counseling them and they were like really surprised, are there any themes that came up? Like, I feel like, for example, like when I would take care of patients in the hospital with CKD, pretty late stage CKD, and we would be serving meals and we'd be talking about potassium in milk products. And they're like, really? And like tomato sauce? Like, wait, I can't have milk and I can't have tomato sauce.
Right.
Like we had more conversations than that, but do you know what I mean? Was there anything that like
Oh, yeah.
recurrently comes up that people are like, really? Because we probably would
Yes.
feel that way too in
Okay.
primary care, being like, oh shoot, we should probably
Oh,
talk about
yeah. So with diabetes management, and when we talk about like, so starting with foods, and of course like the focal point being like carbohydrates, it's
Mm.
really rare that anybody talks about like the blood sugar changes that happen with fat and protein, or yeah,
Yeah.
or even low, like even very, very low carbohydrate vegetables like, green beans, broccoli, cabbage, all that. But really, you don't see that unless somebody's wearing a CGM, or they just kind of have to check their
Mm.
blood sugar a little bit more often. So if you have somebody that is still, going pretty low carbohydrate, or if they have kind of a lean and green meal, and you're watching a CGM and you're pointed out to them, and maybe it's like a higher fat steak, or beef or something, or if there's a lot of oil on something, and then it's like this late little rise, and it's not an aggressive rise, but like, what is
Mm.
that? They didn't have any carbohydrates at
Mm.
that meal, and where you can see that, where some of the protein and the fat, well, you'll still have a response. It's not an aggressive surge, but I would say
Mm.
that's a big surpriser for a lot of people. And
Mm.
when you look at like insulin management with that, especially if somebody's wearing an insulin pump, there's different tricks that we can use to kind of combat that, like a post meal bolus based off the amount of protein and fats, and they can combat
Mm.
that without just waiting to go high and like get a correction to come
Mm.
back down.
Mhm.
Another really big surpriser for blood sugar spikes, for not everybody, but we see it a decent amount, especially if they're wearing a CGM, is coffee. Caffeine, like anything that's a stimulant.
Mm.
So they'll wake up cruising really good, and then even if they just have like a black cup of coffee and it's 100 milligrams of caffeine and that stimulant, you see that like go up. So there's a lot of times that we have to teach
Mm.
that patient, this is getting into type 1 and like insulin dosing, or type 2 like resistant on insulin, where they have to input some carbohydrates for that, because we see the response to get ahead of the spike,
Mm.
because it's one of those things that even though it might be 0 calories, if there's no sugar, no creamer in it, it still
Mm.
can cause a blood sugar response to it.
Oh my God, that's so
Yeah. So kind
fascinating.
of some of the like non-obvious things that get really
Yeah.
interesting with time. Yeah.
Yeah. And do you see that with other caffeine related products like
Mhm.
tea or soda?
Energy drinks.
Yeah, yeah.
Tea, I don't see quite as much unless it's like a
It's pretty
really
low
large
now.
quantity of like iced
Yeah.
tea.
Yeah.
So I do have some that, even with unsweetened tea, and not even putting like an artificial sweetener, because there's that kind of that potential that artificial sweeteners, like the body can't distinguish a difference. There might still be a little blood
Oh,
sugar response.
interesting.
So that's kind of,
Interesting.
but even unsweetened tea in the large quantities, you can see it. You can also see it with nicotine. So for smokers,
Mm.
I can sometimes be like, is your smoke break at 2:30 every afternoon? And I see this little spike in there. But
That's so interesting.
those really high caffeinated, oh, I can't remember some of the brands, but they can be sugar free, like something like a Red Bull. You
Yeah.
can see it. Yeah,
Yeah.
you can see it there too.
Wow.
Especially because a lot of those people don't sip. It's like a
Chug.
chug, get it back, yeah, and then go back to work. Yeah.
Oh my goodness. Well, this has been super, super helpful. And you said that there are some resources that you recommend, and you and I can connect
Mhm.
about that. In terms of like, I mean, you have your own custom handouts, it sounds like. And I think
Yeah.
sounds like the moral of the story is that like it's really not about handouts, it's about more of a history taking and a customized approach, and like thinking about what are those lifestyle changes we can make, what are the lower glycemic options. And yeah, any other kind of
Yeah.
like parting thoughts or pearls or Actually, we didn't
Yeah.
even touch on the difference between dietitian and nutritionist. Do you want to put that in real quick?
Yeah. Well, let me say one more thing
Yeah,
about
yeah,
like
go for
with
it.
like getting a history. So just
Yeah.
to be clear, like when we talk about getting a history and everything, those were visits, and I don't know how a lot of RDs are scheduled. Like in our clinic, the first visit with the dietitian baseline is scheduled for 1 hour.
Yeah.
Yeah, so it's
Yeah. That's
this type
true.
of
That's true.
education, this deep dive, like the history taking, the recommendations, talking
Mhm.
about it in response to like with medications and stuff.
Mhm.
This is not a short process. So I'm sure some of your guys be like, I can't do that. Like I can't even do what I
Yeah.
need to do in a 15 or
Yeah.
20-minute slot.
Yeah.
And that's where you just give them like little bite-sized pieces of, hey, at the beginning, we're going to work on no sugary drinks. Like that's what we're going to work on right now.
Mhm.
Then I want you to start looking at carbohydrates, maybe think of them as like in serving sizes and start
Yeah.
reducing there and increasing protein and vegetables. Like
Mhm.
those can be just like little basic things
Mhm.
as long as they have a concept of what, carbohydrates, fats, and proteins are. So these are concepts and conversations that take long periods of time. Like there would be some in my previous place of employment that would be for more like weight management counseling that would be hour and a half or 2 hours. I mean, so it's like
Wow.
huge blocks of time
Wow.
to get the information and have those really deeper
Mhm.
conversations.
Totally. Well, I think that
So
also
just keep that in
reminds
mind. Yeah.
me. No, I appreciate that reflection because I sometimes I can be overly ambitious. I'm like, I'm going to start doing that more.
I know.
Like, oh, hold on. But I think that
Yeah.
also reminds me of we have at one of the clinics I worked at, we had a diabetes nurse educator,
Mhm.
and she had a lot of time to work with patients, and so typically, not that it's the best way to run. Well, I'm not going to split hairs there, but there are a lot of times where the nurses that I've worked with have been really supportive, whether it's for hypertension care or diabetes care. And
Mhm.
potentially that could be an opportunity to partner with them if we don't have the access to a registered dietitian, of like, how can we partner together to have more time with the nurse, get information, and then we can kind of have it be a more time together in general between the two of us type of thing too.
Right. And with things that how they change with like telemedicine and telehealth
Yep.
and making sure, because not, and this goes into that other question that you just asked about with dietitian nutritionists. So with our national board, it's registered dietitian nutritionist, so it's RDN, but not every state in the US has licensure. So in Louisiana, we have a state board, for
Mhm.
licensure. So it's like title protection. So if somebody, like even for like telemedicine, they have to be licensed in Louisiana, of course, like anything else. So that is another option if there's one. And I just did a little bit of quick research. The eatright.org, which is the overarching for registered dietitians, there's a place to search like in your area for
Mm.
registered dietitians
Oh,
that
that's
do
helpful.
telemedicine. So, or just
Mm.
locally or telemedicine.
Mhm.
And a lot of hospitals also have outpatient programs. So that's another option too, of just trying to find somebody
Mhm.
that you can refer to,
That's usually
because
where I
I would
sent.
say most places,
Yeah.
yeah,
Yeah,
yeah.
definitely.
And there also might be classes available as well.
Mhm, mhm.
But don't forget that if telemed or telehealth is an option
I
as
love
well.
that. I love
Yeah,
that. Yeah. So, well, I think that was the thing that you and I talked about before we
yeah.
ever worked together the first time was that there's a difference. There's a dietitian, there's nutritionist. Seems like everybody has different preferences for names, but the national one is RDN. And
Hmm.
every state by state may or may not have a licensure process. So somebody could
Hmm.
be operating as a nutritionist, but not actually have the certification credentials.
Right,
Um,
right.
and
Yeah.
then,
Or, because there's of course now, a lot of health coaches, and I
mhm,
mean there's
mhm.
Instagram influencers and stuff. So I mean ideally you would have that person that has that four or
Yeah,
5 year degree
medical.
and
Yeah,
yeah,
because
yeah.
then you add in complications
National
of,
credentialing.
yeah, of like comorbidities
Hmm.
with, CKD. What do you want to think about in those situations
Hmm.
for sure?
Right.
Um,
Yeah.
and I guess the request that you had, right, was as long as you don't call you a dietary, that
Oh
would be
yes, just don't call me dietary.
nice.
Yeah. So RD works fine by
Yes,
me.
perfect.
Yeah.
Awesome. Well, any other
Yeah.
parting words of wisdom or pearls of practice or
I
requests
don't
you
think so. I
have for
mean,
primary
like
care?
we've, like I said, it's just, I feel like the overarching answer for like all the questions are just that it depends. And it's okay if it depends. That's a hard answer to give because it is just
Mm,
so personalized for every person that walks in the door. And, you know, just as in healthcare, we want to fix and we want to fix. And these are things that take a lot of time to help encourage, you know, just changes in everybody's day-to-day life. So, you know,
Absolutely.
yeah,
Cool.
it
Thank you
takes
so
time.
much. I really appreciate
Yeah.
it. You're the
Yes.
best.
Oh, thanks, Liz.